Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. We cover a lot of things on this program, and tonight I'm excited to cover a new technology, a new way of killing cancer cells. And we have two guests tonight. Our guests are Craig Maki and Dr. Joe Herman. Welcome, Craig, and welcome, Dr. Herman.
Thanks for
Hello.
having us, Dr. Deming.
So, Craig and Dr. Herman are both with a company called HistoSonics, and we're going to talk about this technology, a focused ultrasound, and how it works to kill cancer cells. So, Dr. Herman is the medical director of HistoSonics, and he's also a radiation oncologist. He's also a philanthropist and started a foundation that is called Canopy Cancer Collective that helps patients and physicians and medical centers around the topic of pancreas cancer. And Craig is the area director for HistoSonics, and he is more of a educator and marketer. And Craig and I have known each other for about 17 years, and he worked with another company that kind of helped us get our lung cancer program up and running. But we're going to talk about HistoSonics. Before we do, though, we like to get to know you as human beings first before getting to know you as medical professionals. So let's start with you, Dr. Herman. Where are you from originally? Where did you go? Where did you live when you went to high school?
Well, first of all, thank you again for this opportunity. And I haven't been asked that in a very long time. So I grew up in Maryland in an area called Elkton High School. And then from there, I
And
ended up.
where is Elkton? So I
Oh,
lived in Bethesda, Maryland.
you
Where?
did. Okay. Yes. So it's about 40 minutes east. So it's right before you hit the Delaware border. So I
Oh, okay. The
Delaware.
Delmarva Peninsula?
Delmarva, and then I actually went to college in a place called Salisbury University, which is in southern, which you might know. It's down in southern Maryland, near on the Eastern Shore. So
there's lots of chicken farms
there are Purdue. I got to meet Mr. Purdue at one point, actually.
Okay.
I haven't thought
And
about that in a long time, but yes, I did.
And when did you decide you wanted to be a doctor?
So I played soccer. I was a goalkeeper, and the co-captain of my soccer team was a guy named Jason Fern. And as we finished, right after we graduated, I ended up going into graduate school actually, and worked in Bethesda. I worked at NIH for a little while, and I lived in Kensington. And around that time, he developed, unfortunately, lymphoma, and passed away from his cancer at 25 years of age. And at that point, I realized that I wanted to be part of whatever I can do to help. I just thought, how can you pass away from lymphoma? And this is at that point where there was already a lot of options. And that's where I started getting really excited and involved in clinical trials and research. And how do we make sure that that patients don't pass away from their cancer, and that we can provide hope.
Where did you go to medical school?
Went to University of Maryland, and right, in the city, and it was a really great experience. And then from there,
your residency was done where?
I went to University of Michigan for residency.
Okay.
And ironically, the technology we're going to talk about today was developed at University of Michigan and was being developed when I was there, but I didn't know about it at the time.
Yeah.
So it was in another part of the hospital that I didn't know existed at the time.
Okay. Well, before we jump into the technology, let's bring Craig back. And Craig, refresh my memory. Where'd you go to high school?
Yeah, so not too far from where I sit right now. I'm in Plymouth, Minnesota, where the company is now headquartered. I went to Armstrong High School, which is a west suburb of the Twin Cities, back a long time ago.
And what was your claim to fame in high school?
Oh gosh. Let's see. I mean, I played sports, played a lot of hockey here from being from Minnesota. Pretty much born and raised my whole life here in Minnesota, a few years out in Seattle. Went to college at St. John's University, which isn't too far from where I'm sitting, about an hour north up in St. Cloud. And been in the Midwest for the better part of my life. But
Okay.
really enjoy being a part of this community.
Great. Great. So I am going to tell you which one of you is going to start by explaining to those who maybe wonder what's the name HistoSonics, what does that mean, and what is this treatment that we call histotripsy? So, Joe, do you want to take that?
I'm actually going to let Maki do it. Maki's
Okay.
been with the company for longer than I have, and I think he does a wonderful job. And then what I can maybe do is I'll jump a little bit more into some of the patient selection factors and side effects and all that. So Maki, I hope it's okay. I know we didn't discuss it,
Sure.
but
I think I can handle this one. I'll leave the harder ones for you for sure. So thanks, Dr. Deming. Yeah, so I've been with HistoSonics now for a little over 6 years. And for the audience, HistoSonics is the company that's brought histotripsy to clinical use. Histotripsy is the use of focused ultrasound to create acoustic cavitation in the body. It's high intensity ultrasound that's delivered in a micropulsating way that creates a negative pressure that pulls gas out of the tissue within your body to create a little tiny bubble cloud, just a couple of millimeters wide by a few millimeters long. And it's that little bubble cloud that rips cells apart, mechanically liquefying them. So today we use this technology to non-invasively treat patients with liver tumors. We received our FDA clearance back in October of 2023. And over the past 18 months have worked with partners across over 100 hospitals across the United States, some international as well, and have treated over 2,000 patients that have primary liver tumors in the form of HCC and cholangiocarcinoma, and many patients that have metastatic tumors that have unfortunately have metastasized to the liver. It's a non-invasive platform that's a robotic type device that delivers the sound energy in an outpatient procedure. So the company itself has brought this to market. As I mentioned, it's currently indicated for liver. We have ongoing studies to broaden those indications into kidney and pancreas and beyond. And we can talk much more about that.
Yeah. So basically, it's a very focused ultrasound. And so when I explain it to people, they go, ultrasound, because they might be thinking about getting an ultrasound of their breast or getting an ultrasound of, the baby, and they're wondering, what is this? So I often say, well, you probably have heard of lithotripsy, where you can basically crush a kidney stone with ultrasound energy, so that anything that can impart energy to a cell has the potential for killing it, but that in this situation, instead of focusing on a stone, we're using it and focusing it on a tumor. Obviously, we can kill cancer cells by focusing radiation, focusing heat, focusing freezing. The key, I mean, you could kill cancer cells with a hammer, but the key is, how do you kill the cancer cells without killing the structures around the cancer cell? So this technology has the ability to kill cancer cells without actually damaging a blood vessel that might be right next to it. That's in my mind the kind of the magic, or the reason why this can be so beneficial, is that it can kill cancer cells without seriously damaging important structures next to the tumor. How does it do that?
That's right. And so how I explain this to family members or friends that might not be in the medical space is, everyone's familiar with ultrasound for imaging purposes. And if they imagine what an imaging probe looks like, it sort of fans out and provides low levels of ultrasound to provide a visual. What we're doing is taking this fanning out and creating a focus point. So instead of spreading out that ultrasound to provide a view, we take an angulated treatment head that has all of those elements pointed at one point within the body that's about 14 centimeters depth from the treatment head. So you're inside the body. And we use very high amplitude. So not low continuous waves, but very high micropulsating waves that creates this negative pressure point. And that little bubble cloud that I mentioned earlier is very focused. It's very precise. And because it's creating this rapid expansion and collapsing of bubbles, it's kind of like a little tornado or a little blender that's physically ripping these cells apart, leaving behind a completely acellular slurry. So unlike other modalities that might exist today that have a thermal mechanism of action or a freezing, or even in the world of radiation, there is, for good intent, a continued gradient spread that occurs to create a field effect. This is physical. So it's ripping apart cellular structures like cancer cells and hepatocytes in the liver, leaving behind that slurry that's completely acellular and non-viable. But at the same time, because the structures that are so important within our liver, like vessels and bile ducts or the liver capsule, are more collagenous in nature, they are resilient to the forces of this little bubble cloud. So we're able to treat effectively, completely, but also do it in a very safe way in preservation of those structures that we don't want to damage. And we've even found an opportunity to treat patients that might be dealing with a little bit more and not good candidates for more invasive procedures. And we hope that we bring an option for those patients where other ones might not just might not be as appropriate.
Right. And I'm going to highlight something that you said, that this is not invasive. So the device that creates the ultrasound is external to the body, sits on the surface of the body, right, on the skin,
Just off
and
skin. Yeah.
just off the skin. So you don't put gel and you don't contact the body with the device. It's a few millimeters off the skin.
It's a couple centimeters.
Couple
So
centimeters.
it's a machine that rolls in on wheels. It's not that large. It rolls into the room, and then there's an arm on the end of it that holds that treatment head that I mentioned. The treatment head serves two purposes. It delivers the therapy, and then within the treatment head is that imaging probe that allows the doctor to see very clearly where he or she wants to target, draw a volume around that desired target, and then deliver therapy and watch it in real time. Ultrasound does require some medium, as you mentioned. It can't just go through airs, but rather than put big piles of gel on a patient's abdomen, we have a little bath that sits above the patient's abdomen, and we fill that with degassed water. So we introduce the treatment head. It sits a couple centimeters off, maybe, gets kind of close, and then it treats right through that, through the skin, into the organ, and then to the tumor that it's treating.
Right. And the point I was accentuating is the device doesn't go into the body. There's no incisions. You don't have to, insert it into a body orifice. It just sits on the abdomen, and no incision, so non-invasive. And you mentioned that it has FDA approval for treating tumors within the liver, primary liver cancer, which we call hepatocellular carcinoma. We sometimes use the initial HCC. More common than hepatocellular carcinoma are metastases within the liver. So colon cancer spreading to the liver, or you could have lung cancer or breast cancer. Another primary liver tumor would be a cholangiocarcinoma. So it would be a primary liver tumor. So those are some of the things that, and if I heard you correctly, Craig, your FDA indications are for any type of tumor in the liver. Is that correct? Any type of cancer in the liver?
Yeah, we have a very specific indication for use in all liver tumors, both primary and metastatic within the liver.
Yeah. Let's bring Joe on. And Joe, I'm interested in talking about clinical trials. So how does a new technology get approval? And that's a necessary step to, number one, demonstrating to doctors that might want to use it that it is effective. And then number two, it's also a necessary part of getting insurance companies to actually pay for a technology. There are many ways of treating tumors within the liver. You can have a surgeon actually cut the body open and go in and remove it. You can use radiofrequency ablation to heat the tumor and kill the cancer cells. You can freeze it, cryotherapy, or both Dr. Herman and I are radiation oncologists. We know that you can use, very accurately focused radiation on a liver tumor to kill it. What does this talk just a little bit about how did you go about proving that this technology could do it, and do it at least equally well, or perhaps better with fewer side effects than some of the existing technologies?
Yeah, I think it's been a bit of a journey to get to this point. So really over 20 years of work, starting at University of Michigan, as I mentioned. And really initially it was just working out the ability to create high energy, create enough voltage to be able to create that negative pressure to create histotripsy, as Craig mentioned. And then a lot of animal work over years to be able to confirm that that bubble cloud can in fact be controlled, that it can be placed in the right position, and that it's really constrained to only that area that the physician is really trying to target. So as you can imagine, that took quite a few years, experiments to get to that point. And then finally, getting it into a device that reaches the right criteria and accreditation and such, and regulatory processes to be able to be in the clinic. And so ultimately, it started out with what's called a feasibility study. So in devices, it's a little bit different than pharma, where typically in pharma, you're starting with phase 1 trials to understand initial feasibility and safety, and then you progress to phase 2, and then typically a randomized phase 3 study to get to a point of where it gets approved by the FDA. With devices, it's a slightly different process. First, again, it starts out with feasibility, similarly to pharma. And in that feasibility study, and in our case, there was a study that was called Teresa, and it was named after one of the researchers at Virginia Tech. His mother had cancer, and so ultimately we have a bit of a process where we tend to name some of our feasibility studies over either family members or partners and colleagues within our company that ultimately are committed to again helping their family members and also helping future family members. So the first trial was called Teresa. That study was 8 patients, where the goal was simply to prove that if the physician can target the tumor, and as Craig mentioned, be able to put a volume around that tumor, that immediately after that treatment, that the scan shows that the tumor was encompassed within that volume, and that there was no enhancement or any signs that the tumor was viable. So for example, a lot of times when tumors are alive, they're brighter on imaging. But when you treat with histotripsy, it will change it and make it darker, and that gives you confirmation that the tumor has been destroyed. So the study was successful. It was able to show that immediately after treatment that those tumors were destroyed, and also that the side effect profile was very, very favorable. The most common side effect are patients can have a little bit of soreness. It's described as maybe a little bit of almost like you pull a muscle. It usually subsides within 2 days, and if anything, maybe just some over-the-counter medications are needed. And then also patients sometimes describe having like a flu-like syndrome, where they just feel like they, or even like a little bit of a fever or chill. And we think in some ways that's because when you're breaking up the tumor, you're maintaining a lot of those proteins, and the body may be having a little bit of a reaction to it. And so that reaction can cause those symptoms. Outside of that, it was really well tolerated, and that led to what's called our IDE study, which is really where you're now looking at how do you determine, how it's going to fit into patient care, and ultimately what are some of the indications that are going to help us and also physicians in the future understand how to best use this treatment to help patients as we go forward. So in that study, it was called the Hope for Liver study. It was done both in the US as well as in Europe and also in the UK. That study showed ultimately there were 46 patients altogether in that study between between the US and the EU and UK. And in that study, we were able to show again that you can successfully cover the tumor in over 90% of the cases. And again, the toxicity profile was very favorable. There was really only one patient that thought to have some side effects related to the treatment. I'll get into that in a minute. But ultimately, again, it showed that you could target the tumor, destroy the tumor, and again, the side effects were very minimal. That is the study that led to getting FDA clearance. And after that, since then, we've been doing what's called, commercial treatment. And in that case, physicians across the country have been treating patients with liver tumors, as mentioned, of all different histologies. And a number of those centers are now publishing their outcomes and showing that indeed we're still seeing that consistency of tumor destruction. And then finally, we just had our 1-year follow-up of the Hope for Liver study showing that we do have durable control a year out. So if you see that destruction immediately after, that correlates very nicely with a year later to confirm that durability of treatment.
So, Joe, as you know, cancer in the liver doesn't have a good prognosis. So, hepatocellular carcinoma and cholangiocarcinoma, those are two primary liver tumors, have, and sometimes not infrequently, the extent of those tumors might be such that surgical resection is impossible. And even with surgery or any modality, they can recur and they can spread. Have you been able to demonstrate equal outcomes in terms of survival with hepatocellular and cholangiocarcinoma? Are there, does the tumors have to be reasonably small to be able to be treated with this technology? Is there a size criteria when we're talking about right now primary? Then we'll talk about metastases, but that group of primary hepatocellular or primary cholangiocarcinomas.
Yeah, so I think the first thing is to acknowledge that right now the volume, the maximum volume, what we call our planning treatment volume or PTV, is limited at about 4 centimeters. So at a 4 centimeter limit, that means that in general we can treat tumors up to about 3 centimeters in size, and then there can be some breathing motion. So when you treat, when we breathe, our tumors can move a little bit. So you have to have a big enough volume to encompass the tumor plus that breathing motion. And then generally you want a little bit more margin, maybe another 5 millimeters all around to be able to cover any microscopic disease that we might not be able to see with the naked eye, but would actually be some, microscopic growth. So in general, again, within one volume, it's around 3 to 3.5 centimeter maximum volume. However, we do have the ability to use overlapping volumes. So when a tumor is larger, we will treat with one volume and then move it just slightly over and then treat an overlapping volume, et cetera. So we have the capacity to treat larger tumors, but it does add a little bit more complexity and it can add a little bit more time to achieve that. To answer your question about how we kind of compare, maybe, compared to other technologies, if you look across the literature, across at all the ones that you'd mentioned previously, radiation, the other one is called radioembolization, which is, where you actually take liquid beads of radiation and you go up usually into the groin or into the arm and then thread up into the aorta and then go into one of the vessels called the hepatic artery and then release those beads into the tumor. So with all of those, it's taking some time. TheraSphere or Y90 or radioembolization, they're all the same thing. They're kind of, similar. But it's been about 20 years to get to where it is now, to where they show about 90 to 95% control. That's durable out to even a couple of years now, even 2 to 5 years. Similarly, for the other liver-directed therapies, that I would say that the area we need to be in is around 90% control to be considered, non-inferior from a local control perspective. The one difference I would say, though, is that when any tumors are beyond 3 centimeters, the control rates do tend to drop across modalities and kind of fall down to maybe the 80% range. And that just makes sense because as they get bigger, it can be difficult to treat, or you might run into normal structures and have to be tighter. And then the other thing, obviously, is just the toxicity profile between those. But I think from a local control perspective, at 1 year, we're similar. But obviously, we still need to continue to follow patients longer to see if we have the same durability of response of the other therapies.
Okay. And then let's talk about the metastases. So cancer that has spread from another primary into the liver is more common than a primary liver tumor, but it's often multifocal. So can you use this technology to treat multiple liver metastases? And what's kind of the current world record in terms of how many liver metastases you treat in one setting during the course of one treatment time?
Yeah, and I think, both of us being radiation oncologists, and maybe I can take a quick, because I think this is kind of a comparison also of just time, of what the patients might need to go through to treat many tumors. So with radiation therapy, when you do focused radiation with what we call stereotactic radiation or stereotactic body radiation therapy, ultimately, although it's evolving, there are some centers that are now looking at one treatment to destroy a tumor. But in general, it might take 3 to 5 treatments, or even in some cases longer, 15 or even 25 treatments to kill a tumor. And sometimes you even have to combine that with chemotherapy to destroy the tumor. With histotripsy, it really is one treatment, one procedure, one anesthetic event. It does require anesthesia right now. I think that's one differentiating factor. But we have had patients be treated under what's called Maki anesthesia, which is a little bit less. It doesn't require intubation. That's one of the biggest differentiators. So again, right now we do require anesthesia, but it's a single procedure. With regards to the number of tumors we can treat, the world record per se of what has been treated up to this point is 9 tumors. And there's been 2 centers that have done that, both Cleveland Clinic as well as what's called Celebration, which is an Advent Health Center. And in those cases, the goal was really to debulk all visible disease. And it did overall take a few hours to do it, but they were able to successfully treat. And one of those patients is being written up as a case report and has been submitted. But I think the take home is that we can successfully treat multiple tumors across the liver. Again, most of those were all, again, around maybe 2 centimeters in size. So each treatment to treat a tumor can range anywhere from really a couple minutes to sometimes it can actually be a little bit longer if you have to go through bowel or air or things that are known to sort of degrade the acoustic pathway of sound waves, that we might need more energy, and that might mean more time to treat those tumors. So some of those things are what differentiate the timing that's necessary.
And again, sticking with this group of patients that have metastatic disease to the liver, almost all of those patients will benefit at some point with chemotherapy because the disease, whether it's colon cancer to the liver or breast cancer to the liver, it is a metastatic process. Is there any synergy in terms of effectiveness? Since this is such a mechanical thing, it would seem like it's not the same thing as wanting to have some chemotherapy on board when you're doing radiation, but that's part of the question.
Right.
So the synergy in terms of the effectiveness, but also is there any or side effects that are accentuated by doing the two together?
Yeah, really great questions. So we're learning. I think that's the first thing. The first thing that we're learning that's maybe the easier one is that given the very amazing safety profile, right? Again, these patients really recover quickly. Most patients go home right after the treatment. And again, there's no incisions, no cuts. And again, we're not radiating the tissue. We're just really mechanically breaking up that tissue. So first of all, what happens is by treating it, you actually get healing of that area. You create a treatment zone or even a cavity that then is able to be filled in with normal liver parenchyma. So we're actually creating more normal liver, whereas with some of the other therapies, we're destroying liver. That's important when you think about combination with chemotherapy or immune therapy. So we see a little bit of a bump in liver functions, but then it goes back down very quickly. Outside of that, there's very little side effects with it. So it makes it easier to combine this with chemotherapy or immune therapy. You also don't get the lymphopenia that you see with radiation therapy, and lymphopenia can maybe be inhibitory with immune therapy in some cases. And then the other thing is that we have had patients that get treated with chemo either a day or 2 before or a day or 2 after. And haven't really had any sequelae from that. In fact, some patients, even while they have a pump on, sometimes they have a pump that they wear a pump and then it goes, chemotherapy is being put into the liver in real time. Sometimes they've even been treated while that is being given. So again, it's very safe to be combined with chemotherapy or other therapies. And then as you mentioned, specifically with immune therapy, that by breaking up the tumors mechanically, it's a little bit like a Vitamix in a sense that they always say that maybe don't overcook your vegetables, and or your fruits and vegetables because you want to retain all the nutrients from it. Very similar to this, we're breaking up the tumor, but we're not burning that tissue or or radiating that tissue so that the cells and the antigens, the cells are destroyed, but the antigens and the DNA material is able to be taken up rapidly by the immune system. And then what we're seeing in some cases is it does appear to, in some cases, modulate the immune response and enhance it, even in cases where normally they would be called cold tumors or tumors that don't respond typically to immune therapy. So it's very early. Obviously, this needs to be studied in clinical trials, and we are supporting some trials, which we call investigated sponsored trials, or smaller trials, where centers are really collecting samples along the way and understanding how we can optimally combine this therapy with other therapies moving forward, so that we can optimize that.
So, Dr. Herman, we're going to come back to you because I do want to have a discussion with you about other tumor types, other organs where this technology may be beneficial. But let's go to you, Craig. I have a couple of questions for you. So you are out there meeting with cancer doctors and cancer centers and helping them be aware of the clinical trials and also the FDA indication for this. What's been your experience in early adopters of this technology? And maybe just share a little bit of how much does it cost to buy one of these machines and what amount of training, because nobody other than people in medical school right now learned about this in medical school or residency. So there's probably a little bit of additional education and training that's necessary to learn how to use this. So number one, what's your experience with early adopters, and how much does it cost for a center to acquire this technology, and what type of training is required for the practitioners to learn how to use it?
So I mentioned I've been here about 6 years, but then I also mentioned that we've been FDA cleared for a little under 2. So there's a big period of time there. And of course, COVID was going on that led us up to this period. The company, I think in general, has been extremely proactive in engaging in the community to educate. This is a technology that is novel and unique. The company's done a really good job, and I've spent a lot of that time, as have many of my peers, reaching out to the community across multidiscipline. So this isn't one type of physician that does these procedures. It could be radiologists, it could be surgeons, it could be radiation oncologists. As I think you'll see, the technology itself is quite agnostic. I think the common thread through all of it, whether it's large academic programs or community-based hospitals, we have an equal number of both. And in all of them, it's multidiscipline education and awareness and support for the program at centers that are doing this on a daily basis. So that includes those that are going to use the machine, but as important, if not, well, as important, the medical oncologists, the hepatologists, the family practice physicians that engage with these patients and then are aware of what histotripsy is, and then work them towards through those channels to identify if histotripsy is a good option for those patients. I think the company's done a tremendous job at not only educating, but then also putting plans in place so centers that are interested in bringing this technology to their community hit the ground running. We have as many educators on our team as we do commercial folks or marketing folks and sales folks. And I think that's unique for most new med tech. Like anything, there is an interest in making sure that the product is out there, but the company's invested very heavy in the education and support of launching successful programs to make sure that everyone's as proficient as possible to have strong results. At the same time, as Joe already mentioned, our interests in advancing the research and the data, we have heavy investment in supporting the ongoing research because we know that this is just the beginning of what histotripsy can mean in the liver, but in other organs and beyond. And we want to support that research as well. As far as the cost of the machine, it's not inexpensive. There's certainly more expensive technology out there, but it's about $1 million piece of equipment, a little north of that. On that note, the company's done a very good and proactive job at working with Medicare and having reimbursement codes that pay the hospitals appropriately and cover the costs of the procedure through both private pay and Medicare insurance plans. Interestingly, in our early experience and engagement with those programs, I feel that there's a general sense that this is a good, safe, economical option for patients in many regards as well. So the commitment on the company's behalf is to not only work with the physicians to bring the technology to the facility, but to educate the supporting physicians and staff so the programs are strong, while also supporting the needs of any successful program, which include the economic requirements from the hospital, from the insurance programs, to ultimately make this available for as many patients as possible.
And then what type of training do individuals, say my cancer center were to acquire it?
Yep.
And we've got, as you mentioned, we could have the radiation oncologist or the interventional radiologist or the surgeons could be the ones actually defining the target and doing the treatment, if you will. What type of training is required, or do you provide to those practitioners who are now going to be practicing this new modality of treatment?
Yeah, so as it's a multifaceted implementation program that includes not only our clinical educators in the local site, but also like Dr. Herman and many other faculty physicians that work with the doctors that are going to perform these procedures. It's a heavy imaging-based modality. So we use ultrasound and we layer in MR and CT scans to help enhance the imaging capability for the physician so they can draw those targets effectively, where histotripsy can then deliver the therapy into the liver tumor or wherever the application may take place. So it's a multi-step training that includes virtual education in terms of patient selection. So we're thinking about the right types of patients for the beginning of a program. And as that program grows and expertise grows, then we expand its use into different categories of treatments, as well as on-site training here at our Minneapolis office where I'm at tonight, where we have physicians come in many times a month from all over the world to learn how to use this procedure. Then we go back to the center, back to the community to work on site with your team and support those cases. And more times than not, in fact, probably north of 95% of the time that a histotripsy case is happening, a HistoSonics person is in the room supporting that procedure. We have had some centers that have done hundreds of cases and certainly don't need us there. We still like to be around because we're so excited about what they're doing with this technology.
Great. Thanks, Craig. Let's go back to Joe. So, Dr. Herman, I'm interested in talking about, besides the liver, other anatomic sites that have cancer and what sort of research is being done to use histotripsy in other anatomic sites.
Yeah, so we, in addition to liver, we are also treating kidney tumors. So we've completed first, again, in a similar kind of paradigm as we discussed in the liver. The feasibility trial is called CANE, and that was completed in the UK. In that trial, 11 patients were treated, and that was completed it's about 6 months ago or so. And that data is now being collected and will be presented at an upcoming meeting called CIRSE in Barcelona. After that, we continued on with the Hope for Kidney trial. And in that study, across many centers within the United States, that trial was completed a couple months ago. And we're now collecting data to then present that to the FDA around the end of the year. And we're hoping that early next year that we'll have FDA clearance to be able to move in to treat more kidney tumors. That trial was a little limited to also about 3-centimeter tumors, but we're optimistic that we can expand the indication to treat tumors that are more central, and even maybe get to a point where we can do kind of a nephron or a kidney sparing treatment so that patients don't have to get partial or full removal of their kidney. In addition to that, we have an ongoing study called GANON. That trial is our feasibility study in pancreas, and that's also being done in Barcelona. To date, we've treated 10 patients on that trial. And that trial is a little bit unique. We're really trying to first and foremost make sure that we could be safe. We want to make sure that we could target the tumor appropriately with histotripsy, make sure we're not causing any complications. And then once we show the safety and feasibility of that, we hope to similarly move into an IDE study in pancreas here in the United States. I'll say that, I myself have treated quite a few patients with pancreas cancer over my career, and I'm very excited about the potential of this to not only be able to destroy tumors for patients who can't have surgery, but also maybe be able to, because this treatment can destroy the tumor, but not damage blood vessels or ducts, it may open the door to help get more patients to surgery moving forward.
Yeah. And just to build on that a little bit for those who don't know that, the pancreas is in a location where pancreas tumors in the head of the pancreas, there's so much important anatomic structures that are happening. So the typical surgery is called a Whipple procedure, but it's removing the tumor, but then it's rerouting the digestive system, rerouting the bile system, and that's the difficult part of the surgery, not actually getting the tumor out, but making sure that all of the function of the digestive system continues. So I'm really excited, as you are, because if you can actually, with this little tornado, kill the cancer cells, but not damage the bile duct and the duodenum and the blood vessels that are right there that provide the blood flow to the rest of the gut. And so you have indicated you've treated some preliminary indication that patients don't have damage to those structures.
Yeah, it's again, it's a little early. And the way it works is so far we're very excited about the safety profile. All the patients have been able to go home the same day or the next day. Many of them were able to go on hikes the next day and had very little side effects. And in fact, looking across some of our quality of life indices, very little change in quality of life, if not some improvement.
Mm-hmm.
So I think it's very encouraging. At least we're not causing more complications or challenges. In the initial 2 cohorts, the goal was to try to not treat a lot of cross vessels because we wanted to make sure that we could do it safely. But I think the most important take home is that we can treat the tumor in a very focused way. We can see the bubble cloud. You can treat the tumor, and it does not damage any of the adjacent structures as it goes through those structures. So I think that's really important. Second, there are a few patients that had pain that did get relief of that pain. And then thirdly, we have treated a little bit of vessel on some of them, and we haven't seen any damage to those vessels to date. But again, like anything else, we need to continue to follow patients. One of our first patients that was treated, I just talked to actually 2 days ago, and he continues to have he's receiving treatment for his other disease that he has, but at least from the side effect profile, he does not have any undue side effects from the treatment that was delivered to his pancreas tumor.
Okay, so we started off talking about tumors in the liver, both primary liver cancers and metastases. You have told us that primary kidney tumors are being explored, pancreas tumors, other anatomic sites that you guys are looking at.
Yeah, we're excited. I think again, what's really exciting is that the mechanical nature of this is something that we feel confident can be used across many different tumor types. And a big part of this, as we've talked about, is it's agnostic, or it doesn't rely on the mutation profile or if it's resistant to other therapies. So again, a lot of the other therapies rely on essentially the makeup of that tumor, the DNA status of it, and there could be resistance to let's say either targeted therapies, chemotherapies, or radiation therapies. Because ours is mechanical, it allows us to go to different platforms pretty quickly. So we are moving right now into the first really benign condition, which is benign prostatic hypertrophy, or BPH. And this is where patients can get where their prostate gets enlarged, and it can cause pressure and obviously make it difficult for patients to urinate, and where they get up a lot in the middle of the night, and it can really affect quality of life because patients can't sleep as well, et cetera. And there's a lot of different therapies that are out there to treat this, but all of them are invasive to some capacity. So we're hopeful that this can be a real, just a great option for patients to have. And then in addition to that, the same approach of using histotripsy, and in that case, it's a little different. We move it down a little bit. We're now going through either the belly or we're going through what's called the perineum, sort of the perineal area that's above the anus. And in those cases, we think we can treat completely non-invasive, which would really be an improvement over a lot of the other therapies today to treat that condition. So that's next on the list. And I'll pause there. There's a couple more that we're moving into after that.
Okay, well, you got us into the prostate. So you mentioned BPH. What about primary organ confined prostate cancer?
Yeah, so we're starting with BPH, but that's the approach that we're taking, the positioning, the setup, the procedure in general. All of those things really also set us up to treat prostate tumors. So that's exactly the direction we're going in, and again, to be able to help, that way patients that have prostate cancer that might need to have a decision between surgery or radiation, this provides, yet another option that's hopefully less invasive.
Mhm.
That they can consider.
Yeah, and clearly you'll be looking at what about the toxicity profile? Does it cause impotence or incontinence? Because those are obviously two side effects that other modalities can cause when treating prostate cancer. So exciting. Well, I'm going to turn it over to the audience because they are going to have questions for you. So we will allow those of us in the room, the live studio audience, gets first questions. If you are watching us live streaming right now, you can ask questions as well. Please put your questions in the comments section of the software you're using. But we'll start in the room right now. And Poon, you have the first question.
Yes, I may have missed this, but what's the side effects of the liver, treating liver cancer?
Yeah, so generally the most common side effect is going to be really just a little bit of soreness, and then a little bit of like a flu-like syndrome where you just have like kind of like chills and such, kind of like what you get when you get a vaccine. It's usually short-lived. It lasts maybe a day or two. If in some cases when the physician is treating a very large tumor or multiple tumors, very rarely, less than 1% of the time, sometimes that the cells, when they're broken up, they can get deposited in the kidney, and it can affect the kidney function temporarily. Generally, they've all actually, when that's happened, that's called acute kidney injury, and can be treated with fluids, and usually just over time, it'll recover on its own. There are ways that we can prevent that in some cases that we're exploring, and now that we've been, for example, we could put a Foley in, and if we start seeing any darkening of the urine, that could be suggestive. And if we stop soon after that, we've actually been able to prevent that from happening. In addition to that, sometimes there can be a small clot that can occur. And that's usually, again, when you're breaking up a large volume of the tumor, it can get kind of clot up and within the venous system. It's usually, again, temporary. And sometimes we might have to give an anticoagulation medication or one to break up the clotting factors a bit. And again, if we've given that, it's actually resolved also within about 30 days. The only other is that there's been a few bleeding events. Those bleeding events, there's been 4 that we know of. And again, we are reliant right now to let, our physicians are sharing with us what they see. And in those studies, based on their accounts, we've had about 4 out of over 2,000 patients. And in those events, each time the patients, they get what's called an embolization, where they can go in and kind of block that area. And with that embolization, that have healed. So again, well less than 1%. But even if patients have these side effects, they have been able to recover from those side effects.
Okay, thanks. Gary?
Yeah, I'm curious as to the insurances. I am assuming from what you're saying that the insurance have been looking at this and seeing that this is a good possibility of reducing costs and not only costs, but as you have mentioned, the side effects a lot. So I just curious, is there a lot of activity with the insurance companies to look more into this and see if what they can do to maybe promote it?
Yeah.
Also curious as to the life expectancy of the equipment. Do you have any idea yet as to how long will this equipment last, and how many procedures can you do? And I assume that you're continuing to do research to actually improve that equipment.
So
These are great questions. Go ahead.
Craig, do you want to take a stab at it?
I was going to hand it to Craig first.
Of course. So on the insurance side, the company's, as I mentioned, has done a really nice job, I think, at proactively.
Craig, there's a little bit of an echo for some reason for you.
Turn it I'm not sure why that would be. Is it still echoing?
A little bit. Maybe.
I apologize. I didn't change anything. Maybe I'll continue. Tell me if I should stop if it's too annoying. But the company's done a really nice job, I think, with the insurance companies to proactively engage and educate so that they do cover this procedure. We know in working with Medicare that patients that have Medicare are covered. We did that proactively, and about 70% of the time with private payers, it is being covered. It's not 100%, but our team is very big on the reimbursement side as well. We continue to educate, and like any new technology will face challenges as it becomes a new modality in the medical world. So insurance coverers, payers will question what it is before they authorize payment. We've proactively taken that on, enabling patients to have access to this procedure. In terms of the life of the equipment, so we're about 1.5 years in. We estimate that the machine itself, most have a depreciation schedule of 7 years is a pretty standard rate. But I think what's very unique, and as you also alluded to in your question, this technology is evolving on a daily basis. Behind me, hundreds of people work at this company and continue to advance the capabilities. And what we see today is just the tip of the iceberg. Our partnerships with the 100 hospitals, and we expect to be many more across the country, includes our commitment to work with those centers so that as these new evolutions and enhancements become available, they are updated locally. And so the sites are growing with us and able to move this technology into better use within the liver, but as we get additional indications down the line. So the question is a little bit covered also because we'll continue to update the machine with our partners. So truly it's continuously being updated versus sort of depreciating, if you will.
Okay, great. Next question, Kevin.
Yes. And how many?
How many centers in the world are using this technology?
Right now, I believe we have close to 120 centers that have ordered the device. We're a little over, I think, 65 now that are actively treating patients today. That's because we're rolling these out in a thoughtful way, making sure that these programs have what they need to launch. So we're launching about one program per week. I will say for those that are interested in finding out if there are centers nearby, there's 2 really great resources that you can access. One is, of course, the company website, which is HistoSonics.com. And there's another website called Histotripsy.com. Both are very good for patient information, accessing sites that might have this technology. Like anything, speak to your doctors about histotripsy and ask if this might be the right option for you. We think it's an incredible technology, of course, but there's many options out there. But those are 2 really good locations to find out where it is available today.
Great. Next question.
What about a visible tumor? What about skin cancers and that type of thing? Why wouldn't you use this technology as opposed to cutting it off or burning it off or something like that?
Yeah, it's a great question. We have again, we have what's called FDA clearance to treat liver tumors. We have treated some very superficial liver tumors, like that can sometimes be right up against the chest wall, especially in patients that might have, be skinny or have a low, what we call, basically where there's not much, space between the skin and the liver. And there are a few patients that didn't have any other options or chose to have histotripsy, where we have treated a tumor that's right below the skin. It was a metastatic tumor that had spread from the liver to the skin, or what we call the subcutaneous tissue. It's right below the skin. And we're able to treat both of those, one in the leg and one in the arm, effectively. Right now, the treatment head that we use, it's called the transducer. It looks like a little lamp, basically, is where it has all the elements, is a larger, it's created on purpose to be, it's larger so it can treat deeper tumors. But we are developing smaller treatment heads that will allow us to treat the thyroid, as one example, breast cancer, and also skin tumors in the future, like you said, to hopefully do them more non-invasively.
Great.
We had a comment from a viewer. Mary's watching on YouTube, and she mentioned that this is like Star Trek medicine. And the reason she's saying that, I think, is because you're moving around on a cellular level, which leads me to my next question. I mean, the goal is to get all the cancer. I mean, that's what you want to do, because this is so precise, it's so narrow, it's so small. When you're hunting these things down, is there any danger that you're not going to be able to get it all?
Yeah, it is one of the benefits and the challenge, and these are such great questions. So if you think about it again, and if, on the website you'll see this a little bit more, but again, you remember you have the what's called the transducer, and you have the little bubble cloud that's right here, little tornado, and the robot is moving this little bubble cloud in a very concentric, very consistent manner. So that little bubble cloud is overlapping several times in space within the volume. So you get homogeneous destruction of the tumor within that volume. And it's amazingly precise, amazingly consistent. I will say, when I first started with the company, and I would go to these cases, I was a little bit worried, like, are we going to be able to consistently? Because, I like anyone else, I didn't know it when I first started. And as we continue to see it again and again and again, even in tough locations, like sometimes the tumor can be in tough areas right below the heart or right below the lung. But what's amazing is, again, as long as the physician is able to cover that tumor plus a margin, you're going to get that consistent destruction of that tumor. The one thing I'll just say, though, is it's so precise that if you have a tumor that's right next to, like, let's say the bowel, or, and you're really tight, you're going to cover right next to it. It does protect that. It basically will not destroy that bowel or the normal tissue, but there's such a sharp fall off of if you don't have the tumor within the volume, you can get a recurrence right outside of that volume. So that's where, again, we really encourage our physicians. We have a very extensive training program to be a little bit generous and make sure that they are covering the tumor with some margin.
Okay. Well, great. Well, this has been tremendous. We've got more questions, but we don't have time. So we'll definitely have you back again. So our guests tonight have been Dr. Joe Herman and Craig Maki. They are both with HistoSonics, and they've been talking about a new technology using very focused ultrasound to kill cancer cells. This has been great. Thanks so much for joining us. We're going to say goodbye to you, but hang on. I'll chat with you after I say goodbye to the audience. So if you are watching this show tonight and you know someone that would benefit by watching it, it's going to be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel or the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.